Right, everyone. Good afternoon. It's 1:01 Central in the afternoon, so we'll go and get started. I'd like to welcome everyone to the next webinar in our Beyond the Fill series, which continues the theme from American Pharmacy's Apex conference last June and exemplifies our co-op's mission statement to protect, defend, and enhance the independent pharmacy business model. The purpose of this theme is to help independent pharmacies diversify in targeted, effective ways and to raise awareness with actionable, proven opportunity. Your cost, ROI, support, and most importantly, your time are all considered in each program American Pharmacies develops, and the right partner is key. For any community pharmacy, there's arguably no better place to start than with an official American Pharmacies partner, as each of our partners are strategically selected and thoroughly vetted, so our members never start from zero. In short, we take the time and make the effort needed to confirm a cultural fit so you don't have to. Working with our members who very generously contribute their time, we experience the process together in full, and when needed, work with each vendor to shape expectations and evolve best practices. In partnership, American Pharmacies goes beyond preferred terms alone, aligning only with those who share our focus on innovation and continually reaching for something greater. Today, it's my pleasure to introduce Preston Cranford and Will Burnson with Provider CSAO, who will be discussing clinical billing and reimbursement for services you may already be providing. Some of you met these men at Apex and may have also connected at ThoughtSpot in July. Their experience, service, and attitude have proven effective, and their support of targeted pharmacy growth aligns very well with American Pharmacy's vision. Maybe you've started down the path with clinical billing but encountered challenges with credentialing or struggled to find adequate support when you need it. In proud partnership with Provider CSAO, we're seeing pharmacies overcome these hurdles and a growing list of members implement clinical billing in their practices. With that, I'll hand it over to Will and Preston. Thank you, gentlemen.
All right. Well, thank you very much, Jeff, and thank you to American Pharmacies for having us on today. And good afternoon to all of you. Thank you so much for joining us for the Beyond the Fill webinar series. We appreciate you all letting us steal some time from you to share about our partnership with American Pharmacies and explain a little bit more about how we're helping pharmacies go further in their clinical services model. My name is Will Burnson. I am one of the co-founders of Provider CSAO. Thrilled to be here with my other co-founder that you see there, Preston Cranford. And today we'll be talking through clinical services and independent pharmacy from a slightly different perspective than normal. While many of you have heard about platforms that can bill your clinical services, there are very few who actually talk about how to get paid for these services from commercial medical benefit payers. We'll get into more details about Provider CSAO specifically through the course of this presentation, but to set the tone for now, I'll share with you that our mission is to empower pharmacies as vital community health partners by expanding access to clinical reimbursements, and our hope is that that will ensure better care for all. So with that in mind, I would like to walk through what we will be covering today. First, we will talk about the current pharmacy landscape as it pertains to clinical services. Teaser, there have been immense challenges from all sides to really get these going for pharmacies. Second, we will dive more in depth about current and previous state clinical services in pharmacies, including what has been tried so far, what the limitations have been, and what that has meant for independent community pharmacies. Then I will introduce us as Provider CSAO more in depth to show where we fit into this process. From there, I will pass it off to Preston to spend some time talking through a number of the services our pharmacies have been earning reimbursements for from clinical payers and what that can mean for your pharmacy. And last, Preston will share a few notes on how state scope of practice can affect clinical services implementation and the difference between billing to commercial plans versus MCOs. And then from there, we will wrap up and answer any questions you might have. One last note before we dig in. If you have any questions, we are more than happy to answer them at the end of the presentation. So simply put them in the Q&A chat and they will show up for us. All right, so let's start with those pharmacy landscape challenges. One of them, the first one that I think everyone talks about and is acutely aware of, is that PBM margins are crushing independent pharmacies. So NCPA did a study and found that over 35% of scripts billed are sold at a loss, which means that margins are tough to maintain. And in the year 2024, we lost over 1,100 independent community pharmacies. So it's clear that using that traditional dispensing model alone has not been cutting it and likely will not keep cutting it in the future, especially as we were very hopeful to see PBM reform bills introduced into state legislatures, but then after that, there ended up being more headwinds than we thought. And so in many states, those have fallen short or not passed. And when we include that with the second bullet here, that there's a growing demand for pharmacists to fill clinical care gaps without any reimbursements, that puts a large strain on independent pharmacies. And what I mean by the demand for pharmacies to fill those clinical care gaps is that according to HRSA.gov, there's a projected shortage of over 65,000 primary care physicians by 2030. And pharmacies are increasingly expected to cover this care gap, but no one has really offered any reimbursement or incentive to empower pharmacies to be able to invest into this. And when pharmacies are already facing labor shortages and tight margins, this really only exacerbates this issue of profitability for independent pharmacies and a lack of an ability to keep offering clinical services to patients. And as we talk about critical care gaps, national provider shortage areas are critical for pharmacy clinical care. We can track these over time. There's a website to track these, and they're a really good way to track where these needs are most critical. And what you can do there is if your pharmacy is located in one of those areas, generally it means that the contracting process will be more efficient. Not to say that it can't be done anywhere, it can, but those areas are ones where it's especially important to make sure that we're including pharmacies in these clinical care gaps. One thing that we should note as we talk about pharmacies filling these gaps is that many pharmacies are already providing clinical services that should be reimbursed. But since most pharmacies are not recognized by commercial medical payers, most of these services you're offering at a sunk labor cost. Next, when we talk about a history of clinical services, in a couple words, they're limited and ineffective. So for example, Part B, we're very excited when pharmacies started being able to bill to Part B, but what happened is it ended up being an extremely limited pool of patients. And that pool is becoming more and more limited year by year. Because as years have progressed, we've seen more and more patients opt out of traditional Part B Medicare plans in favor of commercially executed Medicare Advantage plans. So that pool of patients is dwindling. Last year's data showed that about 54% of Medicare beneficiaries had moved to a commercial medical plan. And what that means as a number is that really only between 9 and 10% of all of the American population is covered on Medicare Part B now, which is a very low number. And the benefit to contracting with commercial medical payers is that now you will be able to offer services to your entire population pool. Additionally, with Part B, there was a pretty limited range of services that you could offer. What we found is that really pharmacies could only bill for diabetic education and vaccines. And diabetic education comes with its own set of difficulties to implement, right? You need to be accredited, you need to have space to do it, and there are many more restrictions. And vaccines, really, you're only getting a reimbursement for the administration of the vaccine. So all of the counseling that you're doing for your patients is not that is being reimbursed. We've also found in talking to pharmacies that value-based care can be cumbersome and difficult to track. And since it's done generally one payer program at a time for one service with one payer, pharmacies have found it difficult to implement that at scale because they have to track patient outcomes and they get reimbursed at the end. And so it's difficult to be able to anticipate what your revenue cycle will be at the end of a multi-week long program with those. And so what it comes down to is this. There are very high expectations on pharmacies, and very low incentives offered for them to become involved. And so that is where Provider CSAO steps in. To share a little about us, we are a membership-based network of pharmacies. And what we do is establish, as you see, their direct payer contracts. And so instead of a PTAN that only covers Medicare Part B, and instead of one payer program at a time, the contracts that we set up are much more expansive than what pharmacies have historically seen, because they cover all plans across a payer. So we get our pharmacies contracted rather for commercial, Medicare Advantage, and MCO plans. We established our first contract in 2022, and our goal has been to resolve pharmacy reimbursement challenges in delivery. And the way that we do that is a focus on fee-for-service CPT coding in our contracts. And by utilizing CPT codes with fee-for-service, the scope of services is also much wider for what pharmacies can offer. And we'll cover a little more in depth on a later slide on the range of services that pharmacies can offer. But what we need to know is that since we can base this on the time spent with patients rather than waiting until outcomes are determined, for a pharmacy with tight margins and very little free time, these fee-for-service options are critical to ensuring a successful program that pharmacies can also scale with their patients. Additionally, since payer contracts with commercial payers are private companies, they can also pay pharmacists for what they would like and are generally not as restrictive as state scopes of practice. Now, of course, there are restrictions, right? We don't have pharmacies that are setting broken bones or performing surgeries, but commercial payers will offer reimbursements for things like preventative medicine codes in a state where maybe the Medicaid program might not. So what that means is that pharmacies can move more quickly and advance their clinical practice more quickly than by simply waiting for state legislatures and Medicaid programs. And our goal is that by supporting pharmacies who are needed to offer these services, we can actually empower pharmacies to deliver this necessary care in underserved areas. I'll talk about some of the specific benefits to independent pharmacies when we say that we are expanding access to clinical reimbursements for pharmacies. First, it opens up a wide range of services for which pharmacies can earn reimbursement for. We will dig into some of the codes our pharmacies are billing for later in the presentation, but know that there are dozens of different services that our pharmacies can offer. The second benefit is that there is more efficiency in contracting. So all plans that a payer offers will be covered under that same payer contract, which is different from past payer programs. What that means for you is that you don't have to wait for the next payer program or next service to be determined, negotiated, and established. Pharmacists can simply offer the service, document the process, which I have to add is a critical piece. We must be documenting these services so that we can show medical necessity. But once we've offered the service and documented that process, we can simply bill that to the payer for all of these services and earn that reimbursement. So now what we've got are more services to offer and more patients that we can offer services to. So what these contracts do is resolve both of those issues we talked about earlier with the limited scope of service and number of patients, and resolve both of those with direct payer contracts. An additional benefit is that none of these reimbursements are subject to PBM fees. Since they're all on that medical benefit side, the full value of the claim goes to the pharmacy. There's no ingredient cost. There's only knowledge and care. So the profit margins now are really only calculated by labor cost. The good news is that all of that time is reimbursed, and time spent documenting can be included as you bill that claim. 13 minutes with a patient counseling them, and then you spend 10 minutes documenting and reviewing that service, you would bill for a 22 or 23-minute CPT code. So when we talk about being able to scale this, it is a lot simpler than pharmacies initially thought in the past. And another benefit to independent pharmacies is a massive increase in adherence. Studies show that by integrating pharmacies in the clinical care continuum and supporting and empowering them to be part of it through reimbursements, patient outcomes improve. Studies show that including pharmacies in this care continuum results in a patient being more than 2.5 times more likely to stay adherent. This improves patient outcomes and downstream may also end up reducing DIR fees long term because patients are staying more adherent. A fringe benefit that I'd like to mention that isn't necessarily to independent pharmacies is that by implementing this and empowering pharmacies to do this, the benefits aren't only to independent pharmacies. Patient outcomes can improve, readmissions are lowered, and when we talk about all of these effects of patients staying adherent and having better care and better outcomes, that also reduces the burden on our healthcare system overall. So this is a multi-channel benefit by offering commercial payer contracts to pharmacies that you can get by joining Provider CSAO. So in summary, there is a road to a more profitable independent pharmacy by implementing clinical services. So what I'll do here is compare the current state to what it can be with clinical services. So the first couple items here is that we've seen dwindling profit margins over the past 20 years. And as I mentioned earlier, 35% of scripts are sold at a loss. Additionally, the PBM reform that we were looking for is seeing more and more headwinds. And in fact, the DIR fees that we thought would be lessened, they weren't lessened, we just know about them, which is a benefit to be sure, but it didn't actually have an impact on pharmacy revenue. But when we can bill for the clinical services that we're offering, it can be key to making up revenue for low reimbursement dispensing rates. So for example, if you counsel a patient on a new medication, even if you had to bill that medication at a loss, the 15 minutes that you've spent with that patient, counseling them and talking to them about what potential drug interactions there may be and things to watch out for and supplements they may need to take, you can now make up for that loss. So now we're actually talking about making a profit on some of these fills. And as we speak about some of these consults that many states are even required by law to give, they were previously just a sunk labor cost for pharmacies. But now we can avoid sunk labor costs because you're actually earning reimbursement and that fee for service model for the time that you're spending with your patients. Current state is there is a growing dependence on pharmacies to fill clinical care gaps, but that dependence did not come with reimbursement under current models. But the benefit of, again, establishing these commercial payer contracts is that they will cover a wide range of services. You can bill for the time spent, and in most cases, many pharmacies are already doing these services. So what sounds like it may end up being a large investment in labor and cost, as it turns out, simply do the things you're already doing, only learn to document and bill those, and there's a really low implementation burden on pharmacies. And so as we talk about the different services that our pharmacies are offering, I'm sure many of you kind of are wondering, what are these services and how does it work? And so what we'll do from here is spend some time talking about the services, the most common services that members of Provider CSAO are billing out for. We'll talk about how those differ from previous ways that pharmacies were billing them. And we'll spend some time talking about the different CPT codes that can be used to do that. But from here, I will pass it off to Preston and let him talk us through that.
Thank you, Will, and hello to the American Pharmacies members. And let's talk about some of these services. The first one we're going to cover is one that nearly all pharmacies are doing. 35% of all vaccines in 2024 were given in independent pharmacies, according to Pharmacy Times magazine. And you're familiar with vaccines, and you're familiar with the admin fee that Medicare Part B will pay. But if you're submitting those to commercial or Medicare Advantage PBMs, you may or may not be getting that fee. We have pharmacies that come to us all the time and say that their average reimbursement on a flu vaccine in total sits somewhere between $10 and $20. And some of those are still earning that admin fee. but these PBM reimbursements are still low and still are subject to fees by those PBMs, may they want to charge. What you might not know is that a lot of these commercial and Medicare Advantage payers will receive for the ingredient, the admin fee, but they also pay for the time that you're spending with that patient on your consult. This can be worth of $40 additional per encounter when a patient needs counseling, when billing these out through preventative medicine codes. A good way to estimate the minimal impact of joining a network like Provider CSAO is take the number of vaccines that you're doing and multiply that by 40, because you'll be getting that $40 for each of those immunizations. The key takeaway from this slide is that for each of these vaccines, many pharmacies are leaving money on the table for these clinical services. And a time where a lot of people are having concern about vaccines, your ability to console them is more important than ever. All right, next we'll talk about another service that's already happening in a lot of independent pharmacies. I know I can't see all of y'all's hands in here, but internally think, do you have a MedSync program? And if so, are you reaching out to those patients at least monthly to go through their medication, see if there are any issues, or doing a medication reconciliation call? Each of those is a billable event through evaluation and management codes. So evaluation and management codes can be used in a ton of different ways. They are broken down into telehealth or in-person codes. So for the telehealth side, you can bill for as little as 5 minutes and up to 30 minutes. That reimbursement sits somewhere between the $20 and $40 range for each individual service. And just a heads up for the people that might try some of these claims, a lot of payers will ask for a modifier 93 to signify audio telehealth service only. You also have the in-person MedRec codes. So those are also about evaluation and management labeled codes, and those are broken down into new patient or existing patients. For existing patients, you can make anywhere from $20 to $100 per consult, and you can bill for that same 5 to 30 minute range. For new patients, you do have to consult your patient for a minimum of 15 minutes, but it pays off because that reimbursement on average we see comes in around $80 to $160. And now, to be clear, you likely won't be able to connect with every single patient that you have on a MedSync program each month. However, if you could think about if you could connect with 50% of them, it can be easy to do the math and estimate what that reimbursement might be for your pharmacy. We have a lot of pharmacies that we work with that traditionally had MedSync programs, but had really struggled to get it off the ground. And our first question is always, if you were getting reimbursed for that time that you were spending on your MedSync program, what would that change how you're approaching it? And every single time it is absolutely. MTMs are another service that a lot of pharmacies are offering and are within scope of practice, whether it's national Medicare, state Medicaids, even all commercial payers will reimburse you for them. But the way that pharmacy is currently set up, it's historically been limited to Medicare Part B patients, which means that you're only covering about 9 to 10% of the total population. However, many of the pharmacies that we do establish these contracts with are billing these MTMs to commercial, Medicare Advantage, and Medicaid payers. And we've worked with each of these plans to identify eligibility criteria for these patients, which we can share with our members. The added expansion of patients for who you can bill these services to can have a huge impact on the clinical revenue that you're bringing in from MTMs. So this is a great service to start with if you're new to implementing a commercial clinical practice. Reimbursements, just like the MTMs are just like the evaluation and management, how they're broken into a new patient or existing patient. You'll have that 99605 with the average reimbursement of $55 for that first 15 minutes. Each subsequent visit sits around the $25 range with a 99606. And then they have an add-on code for each additional 15 minutes at a max of 4 per year. That brings an additional $15 to your reimbursement. other clinical opportunities. So our contracts are built around a fee-for-service model, and there's a ton of clinical opportunity that's available through the preventative medicine and evaluation and management codes, like I said earlier. And a lot of those are even required services that pharmacists just aren't getting paid for at the moment. I'm sure many of you, your states require you anytime that there's a patient picking up a first fill, you have to counsel that patient, or particular antibiotics, you have to go through and counsel that patient. And while this was previously time that you had just invested with your patients to enhance their outcomes, adding in the billing for these encounters empowers pharmacies to be able to focus on these services and continue emphasizing community health aspect of why patients go to independent pharmacies in the first place. And it's important to remember that any time that we're talking about a time-based model, so if you're looking at evaluation and management or preventative med codes, even the NTNs, you need to be adding the time that you're documenting into your reimbursement for the coding selection, which our team frequently walks through with our pharmacies to make sure that they're maxing out their reimbursements on that side. The preventative medicine codes, like I said, the first fill consults, antibiotic consults, immunization consults, even in states that allow hormonal contraceptive counseling, these are the same structured codes that you're going to be using for those services. And these are at 99401 through 99404. They're broken down by time and can bill for as little as 8 minutes and as high as 45 minutes. And that time will vary a little bit payer by payer. We usually see on the preventative medicine code somewhere between a $40 to $100 reimbursement, depending on how much time you're spending with that patient. Continuous glucose monitoring is also an area that we have a lot of pharmacies interested in billing. This one won't be time sensitive. This will be more so whether you are providing the equipment or the patient is providing that equipment. Almost every pharmacy that we talk to that's rolling out a CGM program is already offering these to their patients. So we usually see somewhere around $140 on a CGM with an additional $35 reimbursement for the analysis of the data in that CGM test. And we do recommend that for services like continuous glucose monitoring, we think that you should stay in touch with the primary care physician to ensure that these tests are performed as necessary. I'd also like to spend some time discussing, what our process looks like from a pharmacy perspective, so that if you're considering joining the Provider CSAO network, you know exactly what you're getting yourself into. And the first thing that I think is really important to clarify is the difference between an executed contract and getting you recognized as a provider for payment with these medical payers. An executed contract, you're reimbursed at 100% of your assigned fee scheduler, and you were considered an in-network provider. Recognized as a provider for payment will usually have a lower reimbursement. But once you are recognized and you've gotten that confirmation, a lot of payers will let you bill those claims. Our ultimate goal is to have our pharmacists billing in 100 days. And each payer will have a different timeline for full contract execution. We have processes in place to help our pharmacies billing sooner. The first thing that we do is once your credentialing is approved, is we submit a form that we have with different payers, that we have an LOI, a letter of intent, for all the payers that will reimburse providers with an out-of-network program. And what this does is it opens up a billing avenue to you while we're waiting for that full contract to be executed. Usually these LOIs will get our pharmacists reimbursed about 70 to 80% of their prospective fee scheduler. So once we have those established, we connect with each of our members to guide them through their first claims to ensure that they're comfortable billing, because in reality, you don't get to see the benefit of the work that we're doing unless you are comfortable billing. So we make sure that you're comfortable in your platform and also what CPT codes you are going to use and can expand into in the future. One note is some of these payers can take a long time. And while some payers will contract in a matter of 8 weeks, 10 weeks, some payers in more difficult states can take up to a year for that full submission and contract execution date due to just the simple bureaucratic processes. And that's why it's so important that we get you recognized by these payers as quickly as possible so that you can start billing out claims earlier. Once the contract is finalized, what that means for you is that your reimbursement rates will go up. So ultimately, our job at Provider CSAO and our goal is to get you paid as soon as possible from payers so that you can focus on expanding your services early. State legislation, if you've been keeping up with it, there have been a ton of states that have been adding on to the state scope of practice for pharmacists. You know, across the country, legislation is increasingly recognizing pharmacists as healthcare providers. And just a quick reminder, whenever we're talking about scope of practice, what we're talking about is the limits of what services you can provide to that state's Medicaid. So even if you look outside of Medicaid, there are additional services that you can bill and get reimbursed for by commercial and Medicare Advantage patients that don't count towards your scope of practice. For example, those evaluation and management codes and preventative medicine codes, there's no scope of practice language for any provider type on these services, but those are more so up to if the payer is going to reimburse that provider for the time that they're spending. But even the state programs are opening up. The momentum is expanding the scope of practice, creating new reimbursement pathways, and shifting the pharmacist's role from traditional dispensing to being a direct clinical care provider. So for a few of these examples, and some of these aren't even the most recent, but ones that we've seen have had a huge impact on the pharmacy landscape. There we go. So for example, Pennsylvania recently started to accept pharmacists as a level 10 provider in the state or a mid-level practitioner. Giving them mid-level practitioner status opens up a ton of clinical services that pharmacists are able to do within that state. You have Wisconsin, who recently started to reimburse pharmacists for the first time for remote patient monitoring without a collaborative practice agreement, the first state that we've seen do that. You also have Indiana, who just recently, them and Hawaii both had announced the provider status passing for pharmacists, which is a little bit different than provider status for a pharmacy, on July 1st, 2025. And I know that Indiana's went into effect immediately. Hawaii's giving themselves a year to acclimate, so that July 2026. You also have Arkansas. They're actually looking for more pharmacists to be involved in the clinical landscape. You know, Arkansas was the first payer across the board to reimburse pharmacists for evaluation and management codes. And after that, you saw all the commercial and Medicare Advantage payers in the state follow suit. And you're also seeing other states and other payers branch off of that exact same model from the success that they did see early on in Arkansas. So together, these examples show a clear trend, and pharmacists are no longer being seen solely as dispensers of medication. They're being positioned as frontline providers, reimbursed for the clinical services and integrated more deeply into the healthcare system. These policy shifts are not just incremental changes, they're laying the groundwork for pharmacists to play a much larger role in improving patient outcomes nationwide. A lot of pharmacies are already doing a lot of the services that we've talked about today. They're just not getting paid for it. Whether it's an opportunity that's not being billed or a payer that you just don't have access to for that patient. And expanding access for pharmacists to work with medical insurers will fix a ton of the healthcare issues that we're seeing at large. You know, it offers pharmacies a new revenue stream, which is crucial right now through the PBM continuously crushing margins. And it also helps these medical insurers fill the critical care gaps that are quickly expanding, like Will had mentioned earlier in the presentation. If you are interested in learning more about our services and why we do what we do, either please reach out to your American Pharmacies rep or directly to our Director of Pharmacy Success, Randy Rodriguez, and you can contact him at randy@providercsao.com. I also added a little QR code down there on the bottom right So if you scan that with your phone, it'll take you directly to our website where you can reach out and ask any questions. Speaking of questions, I'm sure that there are a ton of them. With this being so new to pharmacies, or even just maybe for pharmacies that have been in the medical billing space but had never gotten into the commercial or Medicare Advantage medical side. So with that, I'll hand it back to you, Jeff, and open up a Q&A session.
If I can add one thing before we do that, just wanted to send a reminder that there is special pricing for APRX members. So if you do reach out to Randy, make sure you let him know that you're an America's Pharmacies member, because they've set up a good deal for you guys, and we want to make sure that you get to take advantage of that with your membership.
Thank you, gentlemen. I would echo that. Thank you, Will. We really appreciate the opportunity to partner with you guys, not just on implementation of this value, but to break down barriers to entry, and of course affordability is a big part of that. The return is clear, but to help folks get started and to maintain that level of partnership with Provider CSAO and of course receive the necessary support. We appreciate the preferred pricing and terms that American Pharmacies has with you guys to help implement this value. So to Preston's point, we'll open it up to questions now. Please drop any of your questions in the chat or in the Q&A bubble there, and we'll make sure all those are answered. We'll hold just a few minutes for any questions that you'd like to enter. All right, first question. I currently use a platform to bill for clinical services and mass vaccinations as an out-of-network provider. What's the difference in getting credentialed as a provider, and what's the difference in reimbursement?
Yeah, I can take that one, Will. So if you're currently billing your immunization as an out-of-network provider, there's going to be a few differences there. The first one is going to be your reimbursement amount. So if you're looking at out-of-network reimbursement, usually what they're doing is taking somewhere between 70 to 80% of what they pay people in network. So you would get about a 20 to 30% higher reimbursement on those vaccines. The other side of it is there's going to be way less issues that you see with, for example, co-pays on those claims. A lot of that coverage comes through a lot better whenever you are an in-network provider.
Thank you, Preston. We'll hold for any further questions, please. Right, here's another question. Once we get contracted to bill successfully with the help of Provider CSAO, do we continue paying the CSAO membership? And if so, what is the contract term length?
Yeah, I can hop on this one. Yes, so part of the membership is the maintenance of those contracts. So upon leaving the network, the contracts would also end with that, since we are the ones setting up those contracts. The length of the contract term is 12 months, and that does automatically renew. There's, of course, a 60-day notification period if you would like to term it. Yeah, and something to remember is on the medical side, it's a little bit different than what you might see on the prescription side. You have to have either yourself or a team behind you to be managing all of those contracts. So it's not as simple as you get a contract and you're good for 1 year or 3 years or 5 years. Whenever you get a contract, you're not even good for 60 days unless you have somebody that's managing that on the back end, doing your attestations, any kind of contract renewals that you may need, and also working with those payers whenever there's an issue with a particular claim or reimbursement rates. So that's what we manage on the back end for you post-contract. And to piggyback yet once more, If something does lap, what happens then is you have to go through the entire contracting process all over again. And not only does that take time, but there may now be a network closure in that area. And so you would lose that place.
Here's another question. I've gotten rejections from Blue Cross Blue Shield that say they don't recognize pharmacists or pharmacies as a provider. Is this a state-specific rejection?
Traditionally, yes. Over the last few weeks, we've been working with Blue Cross Blue Shield of Texas to see how we can implement our pharmacists into their network, and they're seeming very receptive on it. So more to come there.
It may be helpful as well to know what state you're in, and then we can reach out to you directly and talk a little bit more about what the situation is in your specific state.
I thought it said Texas.
Looks like Louisiana.
Oh, okay. Louisiana is an interesting one for Blue Cross. They'll actually reimburse on a few services, a lot of them being vaccines. Whenever you look at Louisiana in general, it can be a little bit limited. But if you want to reach out to our team, our team can walk you through what other pharmacists are doing with Blue Cross Blue Shield of Louisiana, and how they're getting reimbursed for some of those additional services. And I do apologize for assuming that you meant Texas there.
Every Texan is now offended, Preston.
I know. Hey, I'm one of you.
Here's another question. Do we need to have a collaborative practice agreement in place to offer clinical services?
That's a great question, and I can grab this one for you, Preston, if you'd like. So for some services, you will need a collaborative practice agreement still in some states. But the benefit to having a contract directly with this commercial medical payer is that once you have that, you can really focus on the services that you're already providing or that you can provide as laid out under that contract. So most of our pharmacies, once they start billing under the contracts that we set up, kind of forego the need for a collaborative practice agreement. That being said, if that is still something you want for a specific program with a specific physician in your area, Provider CSAO, as an ancillary benefit to members, we also help establish those collaborative practice agreements. To let you know, we won't go find a physician for you to establish that agreement with, but if you have that relationship already, we can work with them to get that all set up and contracted for you. But like I said, most pharmacies find there's plenty of benefit just with the direct contracts, and so they no longer have to give up a portion of the revenue and reimbursements from the services that they're offering, and it just comes directly to them instead.
Yeah, a lot of the services that we see on collaborative practice agreements in 2025 are going to be the ones that are are right outside of scope. So chronic care management is one, remote patient monitoring would be a second. The only one that we see as a third every now and then will be point of care testing if the state doesn't allow it for pharmacists, but pretty few and far apart there.
Here's our next question. Are you currently having trouble contracting with United Healthcare or any other third-party payers?
I would say each payer has their own personality. They have different timelines, different expectations, different things that they want out of you as a provider. United Healthcare, it will be, just like any other payer. They just have a little bit longer times that they take. We have contracts in a ton of different states with United Healthcare, and then even for pharmacies that were newer in the process with, whenever we talked back about getting you billing earlier, we have a ton of pharmacies that are going through and submitting those LOI claims and having a lot of success as well.
Great. Next question. How much space do we need for diabetic education if we are a diabetic educator?
I don't off the top of my head have that answer. But Jeff, if you'll write that one down, somebody on my team definitely will know the answer to that, and I can get that right over to them after this. I do know if you're looking at DSME, you're going to be you're going to need your DSME accreditation, which we can send over a few different groups that are great help for that accreditation. And then another thing to consider is that you're going to be utilizing a G0108 or a G0109 for those consults. And the difference between the two is really just, are you doing an individual consult or are you doing it in a group setting, 2 to 20 patients?
I will add as well that we will get the more information on specifically how much space is needed for that. I do know that one of the requirements is a dedicated separate space, which means a room with a door. It can't just be like a curtain blocking it off. You have to have a dedicated room for that in your practice. But yeah, Jeff, if you don't mind noting that down, we'll get some more research and share that with you so you can disseminate to your network.
My pleasure. Appreciate that. I've got a question for you guys from myself. Can you describe or give us some insight as to how you guys interact with some of the different billing platform vendors in the marketplace?
Yeah, Preston, I'll let you take that one since you lead that.
Yeah, we work with every medical biller. We're also, our team is very familiar with each medical biller, their billing processes, their platforms, which goes to be a huge help whenever we're going through and trying to help our pharmacies with some of these issues. We are well aware that some billers may not be the most responsive at times, and some better than worse. And so Provider CSAO is always here to step in and help in those instances. And I'll say as we continue to work more closely with these billers over the next few years, we plan to see even more and more integration with them. But we already do all the work with your medical biller to set up your payer lines, EDIs, ERAs, let them know what your fee schedulers are and what reimbursements to expect. So we work pretty closely with each of the medical billers that are used in the pharmacy space.
Thank you, Preston. Just a quick bit of input on the American Pharmacies front. So, we've got Provider CSAO on as one part, a really important part to help members get credentialed and to get in network with payers. And then we're also engaging different platform vendors as well, the different medical billing platforms. And we've evaluated many at this point just to understand overall the value, functionality, affordability, support, expected ROI, all of those important things, and including a right cultural fit to ensure the best overall experience for our members. And we're presently speaking with several. We'll be beginning some pilots with some of your member peers very, very soon, and looking to finalize partnership agreements with the right partners in that space too, ideally multiple, to give members options. So that's coming soon. We'll of course keep you all in the loop as that progresses. Additionally, we've also created what we're calling our Clinical Services Council, which is consists of members who are pharmacy professionals, largely among our membership, but bringing in the right minds and experienced folks who are doing this successfully on a regular basis now. Ideally, just to continue to have them talking to each other, to bounce off ideas and things that are working in their pharmacy environments, and then to draw best practices from that we can share with all of our membership to help everybody grow stronger together. So know that these things are happening in the background and progressing on a consistently regular basis. Right. I do not see any other questions. We'll hold for just another moment or two for any other additional questions anyone may have. Will, Preston, anything you guys would like to touch on while we're holding for more questions? No pressure.
Now you put me on the spot, Jeff. I guess I can kind of button this up and put a bow on it as we think about ending with kind of a metaphor to show how we work. You may notice the CSAO at the end of our name is very similar to a PSAO, and that's because our goal is to operate in the same way. So you join us, we will set up the contracts for you to expand that access to them. And so oftentimes we find that that helps to picture where we fit in to this whole process to empower pharmacies to begin billing out and establishing their clinical practice.
Thank you, Will. But with that, we seem to have reached the end of our questions, so we'll go ahead and wrap up today. I'd like to again thank Will and Preston for today's presentation. Please know that these folks are accessible to you all as needed, or if American Pharmacies can support you in any way, please reach out and let us know how we can assist. Thank you, everyone, for your time and for joining us today, and I hope everyone has a great rest of your week.